in a patient who has a medial meniscal tear, they may have a lot of swelling. Because they have swelling, they may not be able to get into full knee flexion. So that's why instead of going into hyperflexing the knee, we bring it to about 90 degrees. I like to hold, I'm going to take your shoe off, which we would have done first. I like to hold the leg this way instead of at the ankle because it puts a lot of stress on the ankle. Here, bring her into 90 degrees of flexion. We could add more hip flexion if we wanted to, but we can stay here. And I'm going to internally rotate while palpating the medial joint space, internally rotate, little bit of valgus stress, bring her into extension to try and get the click. The way you may have been shown previously was external rotation, valgus stress to try and get the click. At this point I will accept either because they're national board sources. Evans shows internal rotation, maximum flexion the patient can give you, bit of valgus stress into extension. Cipriano shows the opposite. External rotation, valgus stress into extension. I'd accept either. So when we go to test the lateral, it's just the opposite. I'm going to bring them into external rotation, little bit of varus stress, extend, or internal rotation, valgus stress, and extend. So when we look at this, a positive is pain and or clicking in the knee. Now the greater the angle of flexion, the more the posterior the tear is because the femoral condyle is riding on the meniscus. So the greater the knee is flexed when the positive occurs, we're testing the posterior horn and then slide and roll across to the anterior horn.